Hi, I'm Stephen Gray. We're here in Miami for a roundtable discussion to discuss healthcare cost and ways to reduce it. Joining us in the room here is President Shalala, President of the University of Miami, Dean Pascal Goldschmidt of the University of Miami School of Medicine, and Dr. Ralph Sacco, the Chairman of Neurology. And joining us remotely from Boston is Dr. David Cutler of Harvard, economist and advisor to the White House on healthcare policy. We're going to talk about 4 topics here. I thought we would start out with an overall, with an overview of healthcare spending in general. Now, you controlled Medicare and Health and Human Services for 8 years under the Clinton administration. So I thought you'd be the perfect person to tell us how big this problem is. How much are we spending?
Well, we're spending a lot of money. This year we're going to spend $500 billion on Medicare alone. And, of course, with healthcare reform, we're going to add more people to Medicaid, which will tax the states. Personal health spending, I think, is about $1.9 billion in this country. 40% of that is probably what the feds pay for: Veterans Affairs, military, Medicare, Medicaid, the Indian Health Service. The challenge is, of course, that Medicare spending is expected to continue to go up as the baby boomers come into the system. And what the new health reform bill does is try to slow down that growth. Now, everybody talks about cuts, but what they're really doing is trying to slow down the growth from about 6.8% to about 5.5%. And that's why the new healthcare, one of the reasons why the new healthcare bill is considered revenue neutral. They added some taxes. They're cutting an existing Medicare program back a little bit, the Medicare Advantage program. We've been overspending there, giving the insurance companies more money than they really need for high-quality care for that population. And we're going to go after waste, fraud, and abuse and a whole bunch of other things to try to hold down spending. No one's seriously talking about dramatic cuts in spending. What they're really talking about is slowing down growth over a significant period of time. And there are all sorts of things in the health reform bill that we might talk about that will help us to do that. But the truth is we haven't been very good at doing that. Mm-hmm. We have some ideas. We've tested out some things, but we need to take it on. We just don't have that kind of money. We're talking about 17% of GNP. Mm-hmm. It's more than anyone else in the world spends. And a lot of it goes to specialists. Our population isn't less healthy than anyone else's in the industrialized world, but we just spend more because of the way our healthcare system is organized.
And so now we'll talk as a roundtable group here. Let's talk about some specific ways to cut spending or try to reduce that growth. And we could talk for several hours on this. So I thought we'd focus on a couple of areas. And let's talk about the doctor portion of overall spending. Can you put that? What percentage of the overall pie is that? And then it's this in the news now is every year they keep doing a doctor fix. There's supposed to be a 20% cut, but that never happens. And what is this doctor?
Well, why don't we bring in David into this conversation, because he's really spent a lot of time thinking about costs and about this growth piece.
Thank you, Donna. The physician payments are about 20% of healthcare spending, but of course that understates their importance because the physicians control the other part. You know, I think one way to think about this might be to think about kind of prices and quantities. That is, some of the prices that are paid in the U.S. are higher than in other countries, and higher in some areas than other areas, the most notable example being prescription drugs. And also prices that have to build in administrative costs that are higher in the U.S. than they should be. And then the second part is quantities. People who get imaging services that are just giving them radioactive exposure without any benefits. The rate of imaging in the Medicare population has tripled in the past decade, and there was no sense that we were too low then or where we are relative to the optimal rate. people getting surgeries when medical management will do just as well. So it's kind of rationalizing the care that people get, the actual care, in addition to how much is paid for it. And I think on both of those dimensions, we really need to the system is going to have to take action. We have to support the system taking action.
There clearly is too much protection, though, by the Congress of certain industries, particularly for the government programs. I don't think anything drove me crazy more than the fact that we could actually go out down the street from the department and buy certain things cheaper than Medicare was allowed to buy them, simply because we had locked-in prices or locked-in ways in which we had to do things. And that was really members of Congress protecting industries in their states. And that, of course, helps run up the bill. And we don't talk very much about that, about the fact that it's almost impossible to get decent prices for oxygen or wheelchairs or lots of other medical devices. We're at the mercy of really a protectionist policy of the Congress.
While you brought up that topic, really
Yeah.
the biggest issue there is Medicare being unable to negotiate prices for drugs and pharmaceuticals. Do you think that's politically tenable to have that changed, or Dr. Cutler had mentioned this in his New England Journal paper? Are there ways that Medicare can get around that and effectively outsource the pricing, which they're talking about doing now? Do you see any ways where pricing restrictions might be lifted?
Well, first of all, the government now negotiates drug prices. It negotiates some vaccine prices, some prices. The states will negotiate prices for Medicaid patients. VA gets big benefits from the pharmaceutical industry and gets a break on prices. So that the government, where it has a pool. The industry, of course, is scared to death of the idea of the government, with its huge pool, negotiating on behalf of millions and millions of people. It's very interesting, though. One of the things that the industry did during Medicare Part D, the debate over the pharmaceutical benefit, is it made certain that the government couldn't negotiate prices, but it broke up the country into areas to try to protect the industry. The Congress did, essentially. But more and more, there's been a consolidation of these pharmaceutical benefit managers. So we have larger and larger groups negotiating prices. The question is, who's getting the benefit from those negotiations? And I don't know, David, whether you have looked at that specifically, because there has been consolidation. So we've got the private sector getting the benefit of what the government was trying to get.
Yeah, you're exactly right. There are now 3 big pharmacy benefit managers. There used to be many more. They get big rebates from the pharmaceutical companies, and every so often the businesses that are contracting with them get very upset because they conclude that the rebates are not getting passed on to the underlying purchasers. And that is an example of where the lack of transparency allows people to keep money hidden. That's just that's really hurting us, because the ultimate payers ought to be the ones to benefit from the from the better bargaining position, where we've really shielded them from it.
The government a couple of years ago cut the cost of drugs that were given by cancer centers. Mm-hmm. And it was very interesting, because the doctors yelled bloody murder because they were getting the benefit of the difference. Their argument was, hey, you're not paying us enough for these other things, so we're making up the difference in the margins that we're getting from the cancer drugs. And the government's response was, hey, we can only look at this, and you're getting big margins from these drugs, and we're not getting the benefit of them. And more importantly, the patients aren't getting the benefit of lower costs for those drugs. So this highly fragmented protectionist system that we have really creates screwy situations in which the poor oncologists aren't getting paid correctly, and so they're taking advantage of some margin that they could pick up to supplement some things that they're losing money on. And that's exactly what happens when you don't play it straight.
Mm-hmm.